Hi everyone and welcome back to my channel. Gosh, I feel like so much has been happening in the past couple of weeks, including some transfers that I've done within my work, and I've been sick as well for 1.5 weeks, which was unexpectedly surprising and just ruining my plans. But anyway, I've promised on my Instagram to some of you who follow me there, I'll link my Instagram here, to talk about this new experience of mine in terms of work transfer. So what happened is I work in general medicine ward. For those of you who are new here, I'm a registered nurse. I work for Queensland Health, and my primary ward is the general medicine ward. And I was applying for clinical nurse, clinical facilitator positions, and I was advised to take a secondment in a different ward, whether it's a surgical line or medical line. So I spoke to my line manager, who is my NUM, and I told him that I would like to take the secondment, and within literally a week time, he contacted me back and he said there is a spot for you for 2 months in medical assessment unit / CCU. So it's like a combined unit for cardiac patients and also people who still have some cardiac related problems, but also general medical problems as well. And I said, yeah, sure, just put me in. So everything happened pretty quickly. From the next roster, literally within, I think, 2 weeks or 2.5 weeks, I have started in a new ward, and I've been there now for nearly a month. Yeah, actually it's been a month because we are now in August, entering August. Today's the last day of July. So yeah, it's been a month and it's been great. So I want to share with you guys what I do as a registered nurse in this new ward. But before I start, I wanted to mention on my channel something that I've been consuming religiously lately to grow my hair. Look at my hair, how beautiful it is. Do you remember how my hair used to be really dry and I used to have a lot of highlights? So now I'm growing my hair and it's so nice. So I've been consuming this brand, which is called Collagen & Company. They do collagen in a flavor of watermelon and strawberry, and they do have other flavors as well. This is the only brand I would say that I have come across on the market that doesn't have any aftertaste. If you know what I'm talking about, you probably know a lot of collagen powders, they do have this aftertaste once you start to swallow it, and this one doesn't. And surprisingly enough, like watermelon and strawberry can be such a good combination. It tastes so nice. So you use 2 scoops in a bottle like that. This is the diffuser that they sell on their website as well. So they have contacted me to do a collaboration. They send me this diffuser and they send me as well, I'll show you here in a picture, a full box of collagen powder, which is quite big. I've been using it now for the past, I think, 4 months, and I still have quarter left. So I use 2 scoops or 1.5 scoops that comes with it every day, and I would say that this amount would last you, if you use it regularly like me, about 5 months. So it's a good investment. They also run a lot of promotions like 10% and 20% off. So definitely check them out if you want. I've been really enjoying my hair, my skin. I do play a lot with my press-on nails, but you all seen my nails. My nails are really nice as well. So yeah, I just wanted to mention here, because if I come across really good collaborations from the products that the brands reach out and send me, I always share here, and then I actually myself become a customer as well. So I will be looking into purchasing a new box of collagen powder for myself once this one is finished. Okay, so let's move on to my experience in medical assessment unit. So it's called MAU shortly, and CCU for the cardiac unit. So we have 30 beds, and 4 of these beds are designated to CCU unit. In a CCU unit, you have 4 patients, and the nurses who work there, they work in pair. So you will have 2 nurses for 4 patients. Why is it like that? Because it's quite intense and heavy unit. The patients there are connected to 12 leads monitors to monitor their heart rhythm, and also a lot of them would have would come with different electrical imbalances. So they will be in a lot of different drips and IVs. Plus, they would be in pain. Some of them would be on continuous opioid infusions as well. They would be generally unwell, and you will find that they will have palpitations. They will have IF as well. So they need those two nurses to be there. I personally haven't done my shift there yet. I was waiting to do at least a month in this unit in general, and then ask the line manager to put me there with one of the experienced nurses. So I've noticed so far that the nurses who have shifts in the CCU unit are mostly the same people. Like, they have number of people of nurses in this unit who would go to work only in CCU. And because of that, because of the continuous work there, they would have more experience and more knowledge. So I want to ask my line manager to put me with one of those experienced nurses, so I could try and have a shift in CCU and see how I go. So I was planning to do it sometime in August, maybe towards the end of August, when I have more experience in general in this unit. Apart from CCU, the other cases that we would have pleural embolism, we will have pneumonias, we will still have infections like your urinary tract infections, cellulitis, pneumonia. As I said, we will have patients with virals as well. We would have patients who would come with some sort of ulcers. So assessment unit is a type of unit where we run primary assessments, and then upon the results and complexity of the case, the treating teams, they will decide whether the patient will be maybe discharged home from the assessment unit, or we will be sending them to different medical wards, or if the situation needs to be fixed surgically, then they would go to appropriate surgical wards. So we have two surgical wards. We have orthosurgical ward, anything to do with limbs, or we also have general surgical ward, so we will be sending those patients there. And also a lot of these patients would also go to my home ward, where I generally work, general medicine ward, and they will stay there to continue on further assessments and also treatment options. For example, if someone has pneumonia, so that person would be on IV antibiotics, a short course of IV antibiotics, and then just to lock it up with a little bit of oral short course as well when they will be going home. So for that duration of time, we would send that patient to my medical ward until at least they finish the IV course of antibiotic, and then they would be discharged home on oral antibiotic, just to make sure that everything becomes back to normal. And turnover in medical assessment unit is very high, because if you compare, let's say ED, where I bring most of my patients, the turnover in ED is ridiculously high. Patients there stay a couple of hours, at best maybe like 6 hours. Sometimes they can stay a little bit longer depending on a case, and then they try to transfer them to appropriate wards. So the first ward that most of the ED patients would be going to would be my assessment unit that I'm working in right now, to do more investigations. Because in ED, usually what they do, they would test your urine, they would do set of bloods, they might do gases as well. They may correct your dehydration with IVF fluids, or they might correct your electrolyte imbalances again with the IVF electrolytes, and that could be enough to fix the problem and send person home from the ED, and even place them into short stay. It's like a section in ED where patients are becoming already more or less stable, they can go to short stay and just wait for the upcoming results from the tests that have been done in ED. And if there is nothing serious in those results, then they can actually be discharged from ED to go home. If not, then they will go to my assessment unit. So if you compare the turnover in ED to assessment unit, it's not as crazy and hectic as in ED, but it's still very hectic, especially during the day shifts. And if you compare MAU, which is a medical assessment unit, to medical normal ward, the hecticness of turnover, again, is not as crazy. Medical wards are less busy in that sense. So I, for example, in one shift may change the whole room of my all 4 patients, transfer them to different wards and bring the new ones from ED. We would rarely have elective admissions like you would have in, let's say, medical ward when someone come in for bowel prep to do endoscopy or colonoscopy. But we might have outliers like surgical patients, for example, if the surgical ward has no beds. So we would have those patients in assessment unit until someone would be discharged from the surgical ward and the bed will become available, and then we will send that patient. Sometimes when we go to tier 3 in my hospital, which means that the flow of the patients is higher than the availability of the beds, we would have patients literally placed on beds in corridors and hallways in ED itself, and then we would be pushed to get those patients into medical assessment unit, and then from medical assessment unit, if someone needs further treatment, push them through to the medical wards. So then what will happen in medical wards, they will be discharging patients as quick as they can, though for those ones who can actually go home and it's safe for them to go home. So yeah, I find that in comparison to my home ward, MAU is very hectic in a sense of turnover, and because of that, you as a registered nurse will have a lot of admissions, so you will need to do a lot of paperwork to admit the patients. If you are a nursing student and you have been to placements in a hospital, you probably know what admission process looks like, or at least roughly know and understand. So you can imagine if you are having like the all 4 patients changing in one shift, and sometimes it can be even more than 4, you will have a lot of admission work to do. And this can be time consuming. Of course, nobody expecting from you to do everything if you didn't have time or opportunity to do, because nursing care in a hospital and clinical care in general, it's 24/7. So if you couldn't do something, you can just hand it over to the next shift. But I always try to plan my day and my shift in a way that I can accomplish as much as I can, like within the safety and also reasonable targets, if you know what I mean. But yeah, I still like it. I also like that the heaviness of the manual handling is not as heavy as in my medical ward or any other medical wards in my hospital, because what I've noticed as well is that in medical wards, it's like a dumping ground for patients, and calling it dumping ground, I don't want to offend anyone, but what I mean by that, it's a place where you will have a lot of patients who will be elderly, been living alone somewhere, but not managing themselves well. Some of them would not even have kids in a state to help them, or would be childless, and nobody would actually check on them to know how struggling their life was before they got sick with pneumonia or UTI or really terrible fall with the hip fractures, spine refractures, you name it, and getting into hospital. And when we start to investigate the case, we will find that the person has severe hearing problem, sight problem, and they would be still driving on the road, but because nobody actually adhering to them to check on their lifestyle, people don't know what's happening until that person is actually getting admitted to the hospital, and we can see those problems. And then the mobility will decrease after the falls in majority of the cases, and things like that. So for those patients, it will be in most of the cases unsafe to go back home, especially if they have no services in place, never had them in place, no children who can come and help them, no spouses, or they don't want services. Some people refuse services, or people are so old and their mobility has been decreased by so much that the services won't be the option anymore. So for those people, we will be offering them to take a nursing home placement pathway. And going into nursing home doesn't happen overnight. They have to wait for the available bed in one of the nursing homes. So that takes time. And then we also have NDIS patients who need increase in fundings for NDIS, or who need start from the beginning with the NDIS services due to the new disability or something. And because placement to nursing home, increase in funding for the NDIS, or starting a new funding take such a long time, sometimes up to 5, 6 weeks, and even 3 months, those patients would be staying on our ward, which is a medical ward. And of course, due to their age, due to the disability kinds, they will be very heavy manually. They will be incontinent. A lot of them would be on feeds. A lot of, like, they can't feed themselves, so you have to feed them. A lot of them will be also having NG tubes for the internal feeds as well. A lot of them would need a lot of help to move out of bed using full hoist, full sling hoist. They would be confused as well. A lot of them would have dementia, especially those ones who are very elderly. So you can imagine it's very, very heavy. And I find that medical assessment unit is heavy as well, but in a different sense. I don't mind doing multiple admissions throughout my shift, but at least I don't have to do a lot of manual handling, because it puts strain on my legs, puts strain on my back. And by the end of the shift, I get home completely exhausted, and I'm very honest about it. I feel really exhausted, and then I have to go back again next day to the next shift, which makes it very hard for me. And then when I finally get my days off, I just have no energy to enjoy my life, because my body needs to recover at least for 2 days in a row until I start to feel more or less like a human. So yeah, so this is the difference in that sense. But in terms of other things that I do as a registered nurse in MAU, I still give IV medications. I still give a lot of IV electrolytes. I also still give bloods. I give IV iron infusions. All the medications, including opioids as well, we still do the same. I still have patients with wounds that I need to adhere and change the dressings. We do have, of course, patients who can be double incontinent, can be confused, but because the turnover in assessment unit for its nature of the unit itself is very high, those type of patients do not stay there for long. Maximum a day or 2. Usually it's a day, max 2, and then we send them to appropriate wards, which makes our life a little bit easier in that sense, in a sense of manual handling, which I like. Then we still have med calls, and I have a lot of patients on telemetry. I'll show you here on the picture what telemetry is. It's like a small monitor that they carry with them. So it's a 5-lead monitor that you connect to the patient, and we watch the heart rate. Usually those monitors would stay maximum 48 hours, and it's connected to the set of screens that we have placed in front of the nursing station in medical assessment unit. So if you compare telemetry to the CCU unit, in a CCU unit the patient would be on 12 leads, and they would be connected to the monitor that would be hanging just above each patient's bed. So all 4 beds would have their own monitors, and you can constantly see what's happening to the heart of that patient, and you would be doing daily ECGs. When someone is in telemetry, you need to check their weight, and you need to do daily ECG as well. So the monitors that are connected to the telemetry of my patients are placed in front of the nursing station. I, as a registered nurse who is looking after my 4 patients in my 4-bedroom bay, will not be always hanging out in front of the nursing station to see what's happening on a monitor of my patient. But if the heart rate goes up, or if it goes down, or if the blood pressure jumps in, or if the respiratory rate goes up or down, the monitor of that particular patient near to the nursing station will start to alarm, and everyone can hear that alarm. The only person who sits in a nursing station all the time is the team leader, TL. So the team leader then would come to me and say, hey, Yana, your patient has become very tachycardic, or respiratory rate went up, can you please check it out? And I would go and say like, oh, he just went to toilet, or he's having a shower. So like obviously like you doing a bit of working out, so the heart rate goes up. Or if the leads come off by accident, sometimes patients can displace the lead by accident. They easily can be removed. It will alarm on the monitor, and the TL will come to me and say, or if the battery needs to be changed. So yeah, so those ones are pretty interesting to learn about. And also by working in a medical assessment unit where you have cardiac patients, you will be paying more attention to ECGs and what sinus rhythm looks like in comparison to something abnormal. So we've all been studying this in a university when we were doing Bachelor of Nursing Science, not in very great detail, but it will bring some memories for you once you start to do daily ECGs, or if your patients would complain of chest pain. So one of the procedures would be to do ECG and show it to the doctor, do set of OBS. If it's in a med-call criteria, just press that med-call button. Also, if there is a GTN tablet or spray prescribed for the patient, you can adhere to the PRN section of their medication and give them that as well and see how they go. If the pain is not going away, then definitely, even if the OBS are not in a criteria of the med-call, still confirm with the doctor if they want to do anything else. But in general, if someone complains of the chest pain, always notify the treating team or the RMO, evening doctor, if you are on an evening shift. So what else can I tell you about medical assessment unit? We still work in a ratio of 2 nurses per 8 patients. We do still have ISO rooms, which means we have 4 rooms with 1 bed in it for patients who are on isolation. That could be rhinovirus, that could be gastro, that could be COVID, any viral or any bacterial type of condition. We put them in those rooms. We have a procedure room as well, where we do procedures. We still have all the teams working in this assessment unit as I have them in my general medicine ward. So we still have respiratory, medical, surgical, oncology, and all of that. We still have physio who come to assess the mobility of the patient, even if they stay in short list with us. We still have wound nurse. If you have someone with the complex wound and you don't know what to do about it, or you want to just get an advice on how to dress it, or what type of wound it is, or what stage of a pressure injury it is, you can consult with the wound nurse. We have a special wound nurse in a hospital who specializes only on wounds. We have 3 of them, and they would come and assess it. So you can put the referral, they will come and assess it. We still have occupational therapist who comes and assess patients. We still have discharge planner as well. We still have pharmacist on board who can check all the medications that treating team prescribe to the patients. They can also check patients' medications before we send them home. If you have any questions about any medications, because sometimes treating teams, doctors a lot of times mess up doses and frequency between the doses, and it's crazy. So you can go to the pharmacist and speak to them in person during the morning to evening hours. Usually they stay in there until 5. You can speak to them and just clarify on any questions you have in terms of safety of the medications that you're going to administer. You will be still doing IMs and subcuts. Yeah, so as you can see, the tasks are very similar. It's just the structure of the ward is a little bit different, but the conditions that the patients are presented are very similar. Plus, it has a little bit of the cardiac kind of side to it. So yeah, I hope this video is helpful for you guys. If you're looking into maybe doing your grad year in medical assessment unit, now you've got some insights. If it does look or sound interesting to you, maybe try and put it in one of your options when you apply. I think they still give you 3 options of different words that you can put in order of preference. Yeah, and I still do nights, I still do evenings and mornings. So I'll see how I go in this months. I'm supposed to stay there 2 months, but they have prolonged it for me until the end of September. So if I like it, maybe I'll speak to the line manager and see if they can prolong it for me further and keep me there if they have a spot. So I could practice a little bit more, because so far I've been enjoying it. I'm back again tomorrow on a night shift because I'm taking now 3 days off, because I had a virus and my nose was running, and as a complication of that, on the background of that, my eyes got very swollen and red. So I had some sort of allergic reaction. So I went to GP and he prescribed for me prednisolone twice a day, which is a steroid, and then steroid cream to apply directly around the eye area on my lids. So now I feel and look like a human. I look much better. Before this I looked so bad. Oh my god, like I couldn't open my eyes. Never happened to me like that before. He doesn't know what allergy was triggered by, but he says most likely it was by the virus that you had, because it was nothing else new happening in my life during that time. So yeah, so I'm more or less recovered now. I'm back again tomorrow on a night shift. So yeah, guys, these are the updates in terms of my work. If you have any questions, as always, leave them in a comment section below and I will answer it in my next videos, or maybe directly in the comment section there. Thank you for watching. If you enjoy the information that I provide in my channel, please subscribe and click on that notification bell so you could see when I have upload my new video. And yeah, I'll see you in my next videos. Bye.